You have to look at them. You have to check the diaphragm to see if they are very well positioned. You have to check the fissures, but remember, fissures you cannot see them, but sometimes the right horizontal fissure you can see it on chest radiograph. You have to look at the lungs now, and the lungs and the hilum, and remember that the left hilum is higher by 0.5 to 1.5 centimeters higher than the right one. Okay, and you have to check the heart configuration, shape, and the size. The size by measuring what you call cardiothoracic ratio. I told you how you measure it, but I will demonstrate it on other images. To check the mediastinum, the size of the mediastinum, is it widened? Remember, there are three parts of the mediastinum. On frontal view, there's upper, middle, and the lower mediastinum. And on lateral view, there is anterior, middle, and posterior. You have to check the trachea from up, from the neck, to see the size of the trachea. You have to check if it is central, not deviated to one side. You have to remember that the carina, is it a normal angle of the carina, subcarina angle? Should be between 60 and 70%. If it is widened or enlarged, you should think of something. You have to check the aorta from the ascending aorta, aortic arch, and descending aorta to see if there is no any stenosis or any enlargement in case of, for example, aortic aneurysm. You check paraspinal lines. I'll show you how to look at them. And you have to review some areas. I remember I told you about hidden areas in the lungs. There are areas where lesions are easily overlooked, like apical regions, especially the regions posterior to the clavicles, the mediastinum, and the heart, the trocardiac space, and the hilum, bilaterally, and the posterior to the diaphragm, and posterior to some bones, to ribs, So you should review these areas so that you cannot overlook or miss some lesions. Okay. So as I will keep maybe repeating myself, but it has its value. Before you start analyzing the chest radiograph, these are five things you should look for first as for technical quality of the chest radiograph. Okay. First of all, there's something you start by. Always you start by, it's about coordination or centering. To see if everything is included in the film. You remember I told you coordination is used for when you are exposing the patient. Centering, it's used when you are reading it. The same meaning. You remember I told you upwards, you have to check if sometimes they say if C6, C7 level, it is in the film, or simply if the soft tissue of the neck are within the film. Okay, that's number one. Laterally, you check if the chest wall is in, that the target is the chest wall being within the film, but you can confirm it by looking at the shoulder joint to see if the shoulder joint are within the film. Very important, so that you don't miss anything from, because the chest radiograph is not just for lungs. You can do it for chest wall masses, can do it for bone lesions. That's the reason why I should check if the chest wall is within it. And downwards, you check if if the costophrenic angles are within the film. That is collimation or centering of the film, to see if the centering was good when they are exposing the film. Okay, that's number one. Number two, you have to check first if the penetration is good. You remember what I told you yesterday. Who can remind me what I talked about penetration? When the penetration is good, penetration of the film was good. How do you know it?
Lecturer, we know it when we check KVP, because KVP is for the quality, is the no strength or strong of the
Power.
X-ray, yeah,
Mhm.
power, and the amount of X-ray. For example, I've seen that if the amount of X-ray is high but KVP is not touched, the X-ray will be looking very bad. So, in order to have the good quality, you have to have a correlate the amount of X-ray and KVP.
Okay. Thank you for remembering even those details. I thought maybe you didn't even understand what it means, but it's good. Maybe we'll come back to them. But here, listen very well to me. Here we are talking when you have a film, a radiograph in front of you, want to interpret. Here, you interpret, you are not in the X-ray room, but here you want to interpret. Before you start analyzing, interpreting chest radiograph, these are the 5 things you have to check for first. Okay? So the first one is coordination or centering, where you have to see if everything is included. I told you about that. The second one is you have to check for before you start analyzing, saying what is the opacity, where is the disease, the penetration. I'm asking now, how do you check for good penetration?
Thank
How?
you.
Uh-huh.
To check the penetration, you have to look on the outline of the thoracic vertebra,
Uh-huh.
especially T7 to T12 if they are present of the heart shadow.
I'm not getting you very well.
I'm saying that you have to look if the thoracic vertebra, the outline of the thoracic vertebra can be accessed, or you can access them through the heart shadow.
So if you can see it well, it means there was good penetration.
Yes.
Are you, are you sharing the same opinion with
Lecture.
him? Uh-huh. Yes, I can hear you.
Yeah, yeah. If you can just see the
Your network is
if you
not
can
good.
see the thoracic, like thoracic spine
Mm-hmm.
behind the heart,
Mm-hmm.
that will be good penetration, I think.
Yeah. Yes, mwalimu naniwesera. What you told yesterday? Because remember I told you, I told you that you should see the spine through the heart shadow, but you should see it faintly, not well, not clearly. You remember, I said that when you can see the spine, but faintly, not clearly, that is a good penetration. When you see the spine very well, can see the vertebral bodies, intervertebral disc spaces very well, that is over penetration. I mean, you have used too much KVP, over penetration. When you don't see the spine outline at all, you don't see it at all. You just see the shadow of the heart without seeing the outline of the spine. That is now under penetration. You should increase a bit the KVP. You remember? You understand now?
Yes.
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 Because
Yeah.
listen, and when it is over penetration, it means the lungs are very black, too black to see any small lesion. And when it is under penetration, the lungs are too white. The small lesions will be missed. Okay, that's the way you should check if the film had good penetration of the X-rays. Okay, that is the second thing you have to check for. That number 3 is about if there is any symmetry or rotation. Normally, your target is having a symmetry of the film. Or how do you check for
Is to check the whether the same.
the same? What do you mean by the same? There is any
Anzi, ingana. Distance yo muri left ingana yo muri right.
biva hehe again gusa ni
You first draw the line which matches from that line that you trace it vertically up to that medial end to see if they are yeah.
the distance are the same.
Yes.
Okay.
Yes.
But the first person who answered the question, if you want to mark him out of 10, how much are you going to have? It will be like 0.5. Because at least
0.
because his answer was meaningless. Okay, and that's the symmetry of the film radiograph. And they ask my exam, I ask those kind of questions, and if you answer that way, I don't know how much you'll get. Okay, so that's number 3. If there is no rotation, number 4, you have to check if there was good inspiration or not. Remember, in majority of the cases, routinely, we need a deep inspiration and a deep inspirated film. Who can remind me how to check the good inspiration?
Yes, lecturer.
Mm.
You have to count the anterior ribs. They are at least 6 anterior ribs, which can be above the diaphragm, and exteriorly you have at least 9 ribs, which can be visible crossing the mid-clavicular line.
We are mixing them.
We have seen guys.
First of all, tell me that you have to count them on the right side. That's number 1, not left. Okay? Okay?
Yeah.
You count the
Yes.
ribs on the right side. There is a reason behind, because
Okay.
remember the diaphragms, the hemidiaphragms are not the same level. That's the reason why I have count only on the right side. That's number 1. Number 2, tell me.
We have seen that number 2,
Mm.
if there is good in a deep inspiration, no, if it is not in a good inspiration, we see that in lower lobes, there is not. It will be like opaque. Because
Those are effect of not having the deep inspiration. But my
Yes.
question is, you have a film, you are checking the technical qualities of the film. Now, for you to check if there was a good inspiration, how do you check it?
Lecture. Anterior, you
You
must be able
just
to
count the ribs.
count the anterior ribs at least 6 above diaphragm.
6 what?
6 anterior ribs.
At least 6 anterior ribs on diaphragm. You should answer this way. You count either the anterior ribs or the posterior ribs. If you choose to count the anterior ribs, there should be at least 6 ribs above the diaphragm. And you add even some explanation. The countable ribs above the diaphragm, anterior ribs, they are the ones that can cross what? Tell me.
Midiclavicular.
Line above the diaphragm.
Above the
Otherwise,
diaphragm.
every time you count more than 6 and wrongly, not. See, you should count the ones that cross the mid-clavicular line above the diaphragm if you are counting the anterior ribs. How about the posterior ribs? If you choose to count the posterior ribs, how many? You talked about it. At least 9 or 10, okay?
Yeah.
At least 9 ribs. That is how you check for good inspiration. But remember, a doctor, you don't every time need a deep aspirated film. Sometimes you can need explanatory phase film. See you? I told you and I gave you some reasons behind. And number 5, I didn't tell you what this number 5, the 5th one, angulation. You remember I showed you some diagrams. When you are exposing a patient on X-ray, the X-ray beam should be perpendicular to the body of the patient, perpendicular. But for some patient like ICU, where that distance and angulation cannot be measured, sometimes that perpendicularity can be lost. Okay, you can't make it. And you don't make it now, the X-ray beam will not come perpendicularly to the body of the patient, to the chest. What will happen now? Either the upper part of the body will receive more X-ray than the lower part, or either the left part can receive more compared to the right side. So even the appearances will be different. You can see the upper part of the chest that is too dark compared to the lower part, or the left one is too dark compared to the right side. That is what you call angulation. So especially that can happen for those patients who are not cooperative. So ICU for that portable X-ray, if the portable X-ray is used, or the patient that are not as too sick to be positioned very well. Okay, so that's what you call angulation, and that angulation you should check for it, because if there was angulation, you can call it maybe there was a pneumothorax, or there is an opacity somewhere, or if there isn't. Okay, those are 5 things you should normally check before you start now analyzing. I'll tell you how to analyze a film chest radiograph. I will tell you how afterwards, but these ones, the technical qualities, you should check for first. Okay? I hope you not forget to check them before you start analyzing. So let me show you now how they are done. Like this collimation or centering, can you see, like, because the patient is in the X-ray room, can you see that there is a light here? Sorry. Can you see that there is a light on the patient? Can you see it? Hello?
Yeah. Yeah, we can see.
Yes, we
Can
can
you see
see
my
it.
cursor?
We can see it, yeah.
So that light now, it is coming from the X-ray machine. And it is where now the technician, the radiographer, is trying to coordinate where to send X-rays, where to expose. Okay? And it has 2 effects. Number 1, you don't irradiate unnecessary part of the body. And can even it will even another reason, another advantage, it will improve the contrast of the image, the quality, the contrast of the image. So if you don't collimate that way, first of all, you irradiate unnecessary part of the body. Secondly, it will even reduce the image contrast. Okay. For example, let me show you. The next image is, So can you see, for this image, the first one, they are trying to do a chest radiograph. But look, they have gone far up to the abdomen. This is very long. Even the arms are in, at least, okay, upwards it is okay. Lateral it is not okay because they have gone far, even the arms. Someone can think maybe he wanted just to do X-ray of the arms. It's long. Abdomen, look, at the level of umbilicus maybe, which is very long. And it has even reduced the quality of the contrast of the image. Not only irradiating the unnecessary part, but also it has reduced the quality, the contrast of the image. Okay? That is over collimated film. But under collimated film also on this one, look, yeah, they have cut off the neck, the part of the apex, the neck, laterally. They cut off the chest wall, you can miss, and inferiorly, they can even they have cut off the costophrenic angles, part of the chest. Here you can't know if there is any mass in the chest wall. You can't know if there is any neck lymphadenopathy or apical lesion. You can't know if there was pre-effusion. You can't call it a normal chest radiograph of this shared. You can't. This is an X-ray. These are two X-rays. Should normally, especially this one, should normally repeat. And by repeating, remember what happens. By repeating, you are irradiating again. Again, the patient. So you should make sure that we don't make this kind of mistakes. Okay? Do you get the message here?
Yes, we do.
Okay. Number 2 is about penetration. I'm just demonstrating what the theory behind. And one must be able to just see. When you say in English, just seeing, it means just being seen faintly. Just see, you see it, but not clearly. Just see thoracic spine behind the heart. Okay? Like now here, you can see the outline of the thoracic spine. I can see it. Can you see it? This thoracic spine, can you see the?
Yes.
Faintly.
But if I ask you to tell me about it, how is it? Can you tell me the vertebral bodies? Are they normal? The vertebral spaces, are they okay? You can't
We
tell.
can't.
So that's now that's a sign of a good penetration. Okay? Because you see the spine, can see it, but not clearly. Okay? That's how we check for penetration. Okay? And number 3 is about penetration. I'll tell you, like for this one, okay, not that's still number 2. Over penetration, I give you some examples. This the first image on the left side, on your left, it is over penetration because you can see the spine here. You can see the spine very well. Almost, it looks like they wanted to do the X-ray of the spine. Look, the vertebral bodies that can be seen very well. Not here, but upwards. Meaning, look how the lungs are too dark. Tell me if you can diagnose anything in the lungs. You can't. Can you?
No, you can't.
No.
You can miss any disease in the lung. So meaning this was over penetration. And under penetration, look at this heart shadow. Now the outline of the spine you can't see. You can't see. Okay? If you are not able to see it now, it is under penetration. Look how the lungs look like. They are white. Still, you can miss any small opacity. They are too white, the lungs. because of under penetration. They have given less KVP. The power of X-ray was less, was poor. Okay. Can you compare the two and see the effect of penetration to the
Yeah.
X-ray? Okay, that's number 2. Number 3 is about inspiration. Remember, I told you either you count at least anterior 6 anterior ribs above the diaphragm. Remember this first 2, 3, 4, 5, 6. This one I will not count because the mid-clavicular line is here, and this is not crossing the mid-clavicular line above the diaphragm. So they are 6. And if you want to count the posterior ribs, remember it's 1, 2, 3, 4, 5, 6, 7, 8, 9, even 10. They are 10. So this is a good penetration, the good inspiration. Okay, we call it deep inspiration. And look how the effect. First of all, the heart size will be normal, close to normal. The mediastinum is not widened. The lungs are very well expanded. The diaphragm are depressed. So everything is seen. And again, if I can repeat something on different films, check. Who can tell me how is the penetration here?
Actually, I
How is the
think it's a good penetration
Why?
because I can't see where the vertebral body on heart shadow.
Yeah, you can see the spine, but you can't tell much. You can't tell clearly. You can't tell everything in details. Okay. So
Yes,
this
for
is
sure.
good penetration. Even check how the lungs look like on good penetration. You can see the lungs. You cannot miss anything. You can see the lungs very well. And remember, in the lungs, I will tell you maybe later. In the lungs, what you can see normally it is the air in the alveoli and the blood vessels. Check and look how the blood vessels look like. Remember, the lower part of the lungs, the vessels are prominent because of the reasons I told you yesterday. But check how smooth their walls are. The vascular walls are very smooth. They are separated one by one, one by one. So that's how the normal pulmonary vessels look like on a chest radiograph when it is a good penetrated film. Okay, good penetrated and good deep inspirated film. Check
Yeah.
how the costophrenic angles are sharp in deep inspirated film. Check how the mediastinum size is not widened, it is normal. The heart size is normal. So everything is fine. These are the blessed shadows. The blessed shadows. Check how they even go for the coordination or centering is good. You can see the chest wall by checking if the shoulder joint are within the film. The soft tissue of the neck, C6, C7 are within the film. The costophrenic angles are within the film. So this is a very well done chest radiograph. Okay?
Yeah.
I want you to have this image in your mind. Okay, in your mind. Okay, so the fourth one is about symmetry or lack of, if there was no rotation. You remember what I told you? The spinous processes, they make a line, vertical line, and if you make that line made by the spinous processes, the distance from there to the medial end, I'm not talking about the joint. No. I'm talking about the medial end of the clavicles. The way it is drawn here. The distance from here to there and from there they are the same, meaning there was no rotation. So the film was symmetrical. Okay? Okay? But check here, check on the film here. If you check very well, you'll see that the patient was rotated. Check the spinous process is somewhere there. I can see them. The spinous process, the spinous process, the spinous process is another one. The line made by this, the distance from here to here, and from here to there, are they the same?
No.
Really, not really.
They are very different. The distance are very different, and it means the patient is rotated. And I remember I told you where the distance is bigger, it's where the patient was rotated to. So tell me which side the patient was rotated to.
It's right.
Are you okay? Have you taken your breakfast?
No, it's to left. The distance will be.
The distance is bigger on the left side. I don't know if you are able to see the spinous processes. Can you see them?
Yes, we can.
So the line now, the distance from here to there, and from there to there. So where is the bigger distance? It
It's
is
on
on
the
the left
left
side.
side.
So meaning the patient was rotated to the left side, not right side. Omuntu anywa agenda kimwe ntacyo asanga tukomeje ntacyo. Okay. So now let us talk about the angulation. Remember, this is the fifth technical qualities, the quality you have to check for, and you remember what it means. Can you see that for this film, the upper part is too white, the lower part is too dark?
Yes.
And you? So
Yes.
this is not due to disease. They are not opaque opacities. The reason why they are not even opacities, you will see, check the clavicles, how they are horizonted. Check the symmetry of both lungs are symmetrical in terms of opacity. Meaning there is no disease that has that its intelligence of being that symmetrical the way it is. Immediately when you see this, you think, this is now, it can't be diseased, and they have this symmetry that way. So meaning this was just due to technical issues, because this is now angulation. The patient was angulated, or the X-ray beam was angulated. So when you see this now, don't start thinking of any disease. But what you can do, if you are not able to analyze it, it's better to repeat it. And you just ignore the irradiation, but what the reason for this X-ray was to diagnose any disease. If you are not able to read it, what can you do? Just repeating. Okay. So you get the message about the angulation? Yeah.
But about angulation, I don't understand how you told us it can be the problem of positioning of X-ray machine, but I don't understand how.
How the machine can make this? No, I told you that
Yes.
the X-ray beam should be perpendicular to the body. Perpendicular.
Yeah.
Do you understand how it is?
Yes, it's to make like a 90 angle.
So it means here either the X-ray beam was not, for sure, it was not perpendicular to the body. It was maybe oriented downwards or upwards from the patient. That's the reason why the lower part has this part have received more X-ray than the upper part, and that is somehow okay. And I can understand you. That's somehow how it is a physics. It's a physics of X-ray machine, how it works. I don't know if you have to go into those details of physics for your level. Normally, that the physics is for resident in radiology, because there is what you call anode-Hill effect. Anode-Hill effect is also caused by the angulation, but that is happening in the machine itself. It can even cause this kind of asymmetry in opacities in appearance. Okay. So try to understand the way I have explained it to you and the way you see it. Later, when you come through for rotation, you will understand better than now. Okay.
Yes, sir.
But I told you can recognize this angulation by seeing the look, the opaque areas, they are symmetrical. There is no difference between the right side and the left side. There is no disease that can be that symmetrical the way it is here. When you see this, even the recent one, the recent part, the recent is dark. The recent part, the lower at the bases, they are symmetrical also. There is not this can be symmetrical this way. When you see this, you say, okay, so this is probably technical. Even the clavicles are horizontal, look. So there is not this that can be that symmetrical this way. And you say immediately, oh, this most likely due to technical issues. Okay? Are you okay? So this now, keep remembering this. I don't know if you have a book note where you have written this kind of things, but I will give you these slides so that you keep remembering this. So something new for you. Try to hear this because it's very, very important. Okay? Who knows? Have you ever heard about silhouette sign in geography?
Yeah.
Yes.
You know it.
Yeah, we know.
Tell me,
Yes.
tell me what is silhouette sign. Who told you about it?
It's in the respiratory system.
Who told you? Who taught you this? That course?
Babane Jean Felix. Dr. Babane Jean Felix.
Babani Jean Felix, okay? I know him. So tell me about silhouette sign then.
Yeah, it's a blunt costophrenic angle.
Yeah. Babani ndaje umuhamagare rero ubwo mubaze.
No lecture. No lecture.
No
Ndaje
lecture.
umuhamagare Babani,
This,
mubaze Babani ko abeshya abantu.
That's not silhouette sign.
this is the meniscus sign.
Meniscus sign.
It's
One
about the
person,
heart
please.
border.
That's meniscus sign. Silhouette
Because
sign is the absence of heart borders on X-ray.
Just one person tell me. Sorry?
It's the absence of heart borders on the X-ray.
Absence of what borders?
Yeah, borders of the heart.
Indistinguishable heart borders.
Yeah, we have seen that the silhouette sign can be positive or negative. So,
At least.
yeah, can be positive or negative. When we see the heart borders, the silhouette sign is negative. It's positive if we can't see heart borders.
So let me ask you, at least you tried better than others, but let me ask you, sir, what happens when you cannot see the heart borders? What happens?
Yeah, we see that it's a very opacity on the heart shadow. So we can't distinguish.
It depends on the frequency of the radiation, which are the same.
The silhouette sign is always caused by disease, opacity.
Yeah,
There is an opacity. And the silhouette sign is not only for the chest radiograph. It can be anywhere in the body. Silhouette sign can even be used in a CT scan. in anywhere. Silhouette sign, it's when an opacity. By the way, do you understand what is the opacity?
Yes.
What is opacity?
It's when it looks like whitish.
Exactly. It's the white
So
area, abnormal, but abnormal one.
yes.
Abnormal one. Okay, opacity, we used it to know abnormal appearance of something, either in the lung or somewhere else. But now, listen to me. I just wanted to know if you have an idea, but you have an idea about the silhouette sign. It's silhouette sign is when two opacities of the same density being in the same plane. In the same plane. Do you understand? If in the same plane, that's when you can't see the margin of each of them. And again, that's number one. Number two, the silhouette sign is not just used for the heart. Okay?
Yes.
It can be used anywhere else. If you cannot able to see the diaphragm due to opacity, that's a silhouette sign also positive. Okay? Silhouette sign is not for the heart. Okay?
Yes, lecturer.
Silhouette sign, it's when two structures, one is just abnormal opacity, that are in the same plane, you are not able to see the margin to outline the margin of the normal structure. Like for the heart, as you said, if there is any opacity, but that opacity should be in the same plane. The same plane, the same level, I mean. That's the reason why for the heart, do you know the location of the opacity that can cause a silhouette sign positive for the heart? It's an opacity that is on the right side, in the middle lobe, and the left side in the what you call lingular segment. Because those two areas, they are the ones that are in the same plane as the heart. The upper lobe on the right side, the lower lobe in the right side, they are not in the same plane as the heart. They are not in the contact, what if I want to mean. They are not in the contact of the heart. But the same, the upper lobe, the only part of the upper lobe that is in the contact of the heart on the left side is the lingular segment. And the lingular segment, remember, it is part of the upper lobe on the left. But the lower lobe of the left side, the lower lobe of the heart or the lung, it is not in the contact with the heart. Meaning, if you have an opacity in the left lower lobe, you can't see a silhouette sign on positive to the heart. No. If you have an opacity in the right lower lobe, even if apparently they are superimposed to the heart shadow, the silhouette sign will not be positive. The same for the upper lobe, right upper lobe. Even if apparently they are superimposed with the heart shadow, you can't see the silhouette sign positive because those opacities, they are not in the same plane. They are not in contact with the heart shadow. Okay? Maybe let me read what I have written here. First, that silhouette sign first described by Patterson in 1950. It is a means of detecting and localizing abnormalities within the chest. Only 4 different radiographic densities are detectable on a plain radiograph: air, fat, soft tissue, and bone. If 2 soft tissue densities lie adjacent to each other, they will not be visible separately, but if, however, separated by air, boundaries of both will be seen. If they are adjacent, if they touch each other, That's when you can have a silhouette sign positive. Okay? Mwabyumvise sibura? Vuze menshi wabyumvise?
Yes.
But here they said hari aho mweze mubona bavuga umutima se? Nothing like the heart. Hari aho umutima wavuze? Silhouette signs is not for the heart only. Anywhere you can have an opacity that is now swallowing the margin of another normal structure, that is silhouette sign positive. Okay? Sinzi niba mwabyumvise kugira ngo nkomeze.
Twabyumvise.
Wa munyamahanga arimo? Ko atajya avuga? Is coming from which country? Ava mu kihe gihugu?
Eritrea.
Ko atavuga?
Aravuga.
Aravuga ntabyumva.
Kubera uri kuvuga mu
Mwumvise ko atabyumvise.
Avuga mu Cyongereza.
Avuga mu Cyongereza gusa.
Tumwumve nyine.
Nyine mumuhamagare nyine mu Cyongereza.
Yitwa nde se?
Yitwa Silat.
Silat, how are you? How are you, Silat?
Yes, I'm here.
Silat?
Yes.
Ah, you are there?
Yes.
Do you understand what is a silhouette sign positive?
I do.
Explain to me.
Okay, silhouette sign is when two exact opacities are present on the same plane, which hinders the visibility differentiation between the two, in which one is normal structure, which can be the heart or the diaphragm, and the other is usually a pathologic opacity.
Yeah, that's true. You're even saying it better than others. Imagine. Keep answering my question.
Thank you.
Arabarusha kuvuga neza ahubwo niba atabisomaga.
Iyo ni ruswa.
Arabarusha kumva gasa n'uri kubisoma.
Iyo ni ruswa.
No, he was not.
Oya arabizi.
Arabizi pe.
Okay, that's good. So this is now an example of what I was saying. Like here, follow very well. There is a heart shadow, but on the right side, there is an opacity, round opacity. That is in contact with the heart shadow. You miss now the margin of the heart on the right side. But not only the margin of the heart, check also the diaphragm. You remember that the diaphragm on the right side, it's normally very well seen totally. Okay? Look, you can't see part of the hemidiaphragm on the right side. That was also a silhouette sign, meaning this opacity is extending in contact also to the hemidiaphragm. This is silhouette sign positive, but also on the hemidiaphragm, there's a silhouette sign positive also. Okay?
Yes.
And again, I told you this opacity is in the right middle lobe because the right middle lobe is the one in contact with the heart, in the same plane with the heart. Okay? If this opacity were in the upper lobe, even if it's extending behind, remember, like in the lower lobe, it can go up to this level, the lower lobe of the right side, posteriorly. And it can be superimposed with the heart shadow if it is big enough. You can't see this silhouette sign positive because those opacities, they are not the same plane. They are not in contact. Okay? The same on the left side. You remember the oblique fissure is somewhere like this. This is the lower lobe, but posteriorly, the lower lobe goes up there. But this upper lobe, the lower part of the upper lobe, it is where you have a lingular segment. That lingular segment is the one that is considered like the right middle lobe. It is in the contact of the heart. If there is only opacity in that lingular segment, It's when you can see the silhouette sign positive to the heart, because it's only that part that is in contact with the heart shadow, of the heart, by the way, not even shadow. Okay, on the lateral view, they wanted to show how the opacity is in contact with it is in the middle lobe, by the way, because on the lateral view, the middle lobe is the one that is superimposed with the heart. Okay, that aims for it's for the middle lobe. Is it clear here?
Yeah, it's clear.
So another sign then, air brongram sign. Who knows?
I know little.
Felix ntabwo yabibabwiye se?
Yarabitubwiyeho. Yatubwiyeho.
You forgot?
Yeah, but it told us is when we see it's like air in the hilum of the lungs. The lungs. If we see like a hilum of the lungs clearly, like opaque, it's opaque. I don't remember where.
Who remembers? Who remembers? We ntabwo ubyibuka nakumvise. Atol. You are offside, guys. Tell me. Who remembers?
I do. Air bronchogram is it's a pattern.
That is who?
Yes, it's Sirac.
Sirac.
Okay. So air bronchogram, it's a pattern seen on chest X-ray where the air-filled bronchi are seen in a background of opaque.
Thus, I promote you to the 50th year of medicine because you're answering very well.
Thank you.
50th year?
Yeah, I will not give him exam. Wow. How can I? And he knows what I'm teaching.
Not.
Let me answer the questions.
Anjen, hold on.
Oya, uriya ntabwo ari jyewe ariko.
By the way, they are passing through the opacity. And on X-ray, you can see those bronchi. Okay? You can see the tubular structures within the opacity. That sign now is what we call air bronchogram sign. Okay, it is even, I think, written an air bronchogram is a tubular outline of an airway made visible by filling of the surrounding alveoli. By the way, made visible because you remember in the normal chest radiograph, you can't see the bronchi, you can't see them because the bronchial wall is very thin and the content is air. Even the content of the alveoli, it's air. So you can't separate air from air. That's the reason why I cannot see it. So now the opacity now is making the airway visible because it is a sign that is there when there is an opacity. Which opacity? The collection of fluid, or the pass of fluid in the lungs. It's a good sign because, listen to me, there's someone who you have opened the mic. It's a very important sign because it gives you, it tells you that the opacity you are looking is a correction in the lungs. Okay? Because if it is a solid mass, can you get me? If the opacity you are looking is a solid, it's a solid mass. It's a solid mass. You can't see the air bronchium sign because they will not allow the air bronchograms will not pass. The bronchi will not pass through the solid mass. The solid mass will push away the bronchi. Okay, but the collection of fluid will not push away. The bronchi can pass through the fluid collection. So can you get the importance of this air bronchogram sign? It can tell you this is fluid collection or this is solid mass. Listen, 6 causes of air bronchograms are lung consolidation. When you say consolidation is collection in the lung, consolidation normally means there is fluid collection in the lung. Pulmonary edema, yes, because it's also fluid. Non-obstructive pulmonary atelectasis. Atelectasis is lung collapse. It is collapsed, but still some bronchi can have some air passing through it. Severe interstitial disease. Some severe, they add severe because interstitial lung disease can look like alveolar opacity, like a correction of fluid. Neoplasm. Neoplasm here, only neoplasm I know is a bronchoalveolar carcinoma. It's the one that looks like a correction of fluid in the lung. It's like pneumonia or consolidation. And normal expression. Normal expression because the lungs becomes white and you can still see some air within the bronchi. Those are the code where you can see this sign, air bronchogram sign. Okay?
Yes, yes.
Okay, this is a sign. Look here. Can see this is part of the lung, it's magnified part of the lung. There is an opacity in the left upper lobe. I can see this is the left upper lobe because this is the apex. Not okay. Not this is diaphragm, baby. This is left lung. Let us call it left lung. But within this opacity, you can you see these tubular structures, dark structure?
Yeah, we can.
Those
We
are
can.
bronchi with air-filled bronchi. This is now what you call air bronchogram sign, and this is a sign of consolidation. Like here, I am sure that was consolidation. The fluid collection. It is not just for radiography, even for CT scan, you can see this sign. It is even better, well better, it's well seen. Like this is opacity in the right lung on CT scan, and you can see the bronchi within the opacity. In the microphone, you can see the opacity with the bronchi passing through the opacity. This is air bronchogram sign. Any question? How I continue?
No, no any.
Sometimes something I forgot to tell you. Sometimes for the silhouette sign, let me correct this word. silhouette sign. For the silhouette sign, there's something I forgot to tell you. Silhouette sign can sometimes recognize any opacity by silhouette sign only. Sometimes you don't see the opacity is somehow it's not clear. The opacity itself, it's not clear. It's somehow it's a ground glass opacity, or it's vague opacity. You can't tell if there is any opacity or not, but still the silhouette sign positive is there. Sometimes you recognize some pneumonia consolidations by just seeing the silhouette sign positive without recognizing very well the opacity itself. Okay? Mwabyumvise? Tuzareba amafoto bimeze gutyo. Is it clear?
Yes.
Sometimes you don't, what I mean, sometimes you can not see the opacity like the way you see it here. But when you check very well, the margin of the heart, the margins of the heart, the margin is not, it's not clear. It's not clear the way it was supposed to be. Like here, it's very clear. But when you see, you don't see it clear. It's vague. It's not clear. And you ask the question yourself, you say, why? Why isn't it clear? Or the diaphragm is not clear.
Excuse me, lecturer.
So,
I was asking
ntabwo twakumvaga.
if we have the unclear margin,
unclear margin.
Yeah, it
But
can
without seeing the opacity itself.
At that case, I think in the case of, for example, cardiomegaly, we have only the heart which is enlarged, and there is no other opacity around. Even though you can't see the clear margin of the heart. And during the lecture of CVS is where we have been doing with this, and we have seen that in that case we have only heart which is enlarged, but we don't have other structure around which is in the opacity, which is in opacity. Yeah, is that in that case?
I don't believe in what you are telling, the story you are telling me, because the cardiomega itself cannot make the heart margin not clear. Unless there is any opacity, there is pulmonary edema around. Maybe that case it was pulmonary edema. That's making the margin of the heart not clear, not very outlined. I think if there was cardiomegaly, I think that case was about pulmonary edema, cardiogenic pulmonary edema. Because cardiomegaly itself, without pulmonary edema, you see the margin of the heart very well. Seriously.
Okay. I understand, but when you say a clear margin, which can make a clear margin of the organ?
It's an opacity, always opacity. Any opacity somewhere.
Yes.
There is opacity. Okay? Okay, let me continue. This is not a theoretical, we cannot understand it by just talking unless I show the images. Okay? So remember, this lecture is about the overview of chest imaging, or chest imaging overview generally. ntabwo ndatangira kujya muri specific uvuge ngo how to, even if I introduced it, how to interpret chest radiograph or something. We'll have another lecture today where we'll go into details of these signs and show some images. Okay, but now we were talking about, we started by chest radiograph. Now let us talk a bit about chest CT scan. Okay, for people who have never seen just how CT machine looks like, you can look at this machine, and as I am reporting this image they have sent me. Yes. Well, no, I'm sending a report of 1 minute.